Thanks everyone for coming. Today we're just going to focus on the workup for musculoskeletal malignancy. Obviously, malignancy and tumors are a very, very big topic, so James has given me the kind of narrow focus of just the workup. So what to do when you have a patient in your rooms or in clinic that you're concerned of for musculoskeletal malignancy. So what we have to do is we have to break it down into two things. So primary malignancies or working out benign tumors versus metastatic disease in the bone. And that has very important kind of treatment options because the treatment mnemonic completely changes. And then the workup, so we obviously have to talk about the history, investigations, what we're going to order, and then what we're going to plan for once we've made that little diagnosis. So starting with just orthopedic malignancies, you know, we always have to be very aware and cautious whenever someone turns up into our rooms with pain, which seems to be the most common presenting symptom of malignancy. A couple things to note is that primary malignancies present normally in people under the age of 40, and then we have to look at the history. Is very, very important, and the age is the most important criteria. So we'll go through a history, a physical exam, and then we start with simple investigations, and then how to plan and refer further on. So like I said just before, pain seems to be the most common presenting complaint, and people will turn up and, you know, the classic is, you know, the 14, 15-year-old girl who's got knee pain and has been progressing over the last 3 months and hasn't noticed. So progressive pain, and they say the more aggressive this lesion is, the quicker the onset of pain. So people who have a rapid onset of pain over 1 to 3 months, you've got to be more suspicious of a malignancy versus someone who's had this gradually, slowly increasing pain over, say, 6 to 24 months. So the longer the period of time, the more likely it's going to be more of a benign or less aggressive process. Pain at rest is obviously something to be very concerned of. Night pain is a classical feature of orthopedic malignancy. And the other associated symptoms, fever, malaise, night sweats, cachexia, anorexia, but those tend to come later when the disease process is more advanced. So really pain seems to be the linchpin for early diagnosis, and just be aware of that in the different age brackets. And so like I said, duration is quite important. And then going on to the physical examination, obviously you want to look for any deformities or swelling. All of the physical findings can be very, very subtle, and so looking for things like mild increases in temperature, muscle wasting due to pain or inhibition of the specific area around. And obviously it's very, very important that you look around and try to feel for any bony or soft tissue masses. So trying to feel for those lumps in the area of pain. Lymphadenopathy can also be an associated feature with an inflammatory process, but we're also very aware that in malignancy, you know, spreading to the lymph nodes is an important process to pick up. So when we move, joint stability is rarely a problem, but sometimes you can get, due to the tumor, can affect either the muscle tendinous areas or the actual joint itself, depending where it is. So looking at range of motion. And obviously for all the patients we talked about last week in Paget's disease, you can listen to the bruise in the skull. And people with very good ease may be able to hear the rapidly mitosis eating cells. But those are for only the very advanced. So simple investigations. This any patient who comes in and you're worried about malignancy, it starts with 2 orthogonal X-rays. You know, very simple, and a lot can be determined from just good, simple X-rays, high-quality X-rays, and going through them. And we'll talk about a mnemonic of how to try to a matrix of going from there. And it's important that we look at the size, the margin of the lesion, and whether there's any soft tissue X-ray. Now also it's important when you're looking or you're suspicious of malignancy, you have to look at a chest X-ray because you've got to be always very concerned of pulmonary metastases, especially in orthopedic malignancy. So when we do take those X-rays, I'm sure we've all seen this kind of photo. There's varying versions of this in every textbook or presentation on orthopedic malignancy. And basically it's going through the fact that different lesions tend to find themselves either in the epiphysis, the metaphysis, or the diaphysis. And obviously it's hard to get a cortical fibrodysplasia, you know, in the middle of the medulla or in the cancellous bone. So some of the names will give it away. But what you want to do is just have an idea that kind of depending on the location of the tumor or the lesion, it's going to give you kind of an indication of what the possible diagnosis may be. And cross-referencing is always very, very important. Going back to these things, I don't think I'm not at the stage yet where I can remember every single one of these off by heart, but it's important, especially for the juniors, to know that different lesions appear in different locations and to look at that in cross-reference. So when we talk about the margin on a plain film X-ray, this is important for kind of getting that initial thing of what are we going to do. And we talk about this here on the left is a narrow margin. So we have a very fine margin, and sometimes there's the sclerotic ring around these lytic lesions. And so that margin of the transition from what is abnormal tissue or the lesion we're concerned about to what we would consider normal tissue, when that margin is very well defined and in a very small, 1 to 2 millimeter diameter, that's what we can call a fine or a narrow margin. And then when we come across in something like this is what we call a moth-eaten appearance, and that actual transition zone between abnormal tissue, or the tissue that we're concerned about, into normal tissue becomes much less defined. And you can see that obviously the lesion is all in this area, but actually finding where that very specific margin of where tumor stops and normal tissue starts has become a lot more blurred. And then that can progress onto a permeative process when you can see that there's a reactive process going on, but it is impossible to define where the tumor and where the normal bone, where those margins of what the lesion are. And why I've ordered these in this progressive order is because this is indicative of the likelihood of the aggressive nature of it, or the chance of malignancy. So if they have very well-defined margins, you can be much less concerned versus, a wide margin to there is no margin, there's no differentiation between where normal and abnormal tissue stops. So like I said, having good plain film X-rays can be very, very important, and we'll talk about it a bit more. And then the next thing we have to look at is the periosteal reaction. And you can get this lamellar lifting of the periosteum, so that's very, very kind of narrow. And then looking at here, you can see that there's separate, different layers of the periosteum. There's a periosteal reaction in layers. And again, we're progressing from less aggressive to more aggressive. So it's important when assessing X-ray that you look at the margins, the periosteal reaction. And then going on to continuing with this X-rays, this is we call the starburst or the hair on end. There's a whole bunch of different names. Sunburst reaction. So you can see this periosteal reaction is very, characteristic of malignancy, osteosarcoma in the young child. And then the other thing we talk about is Codman's triangle. So you can see that here. So there's this lifting. You can see there's not an ill-defined tumor margin here. You can imagine that on exam you'd feel some soft tissue extension, and as that soft tissue extension, that has lifted up the periosteum, and you've had this periosteal reaction. So you get this triangle periosteal reaction, which they call Codman's triangle. And then that's, again, progressing from simple lifting of the periosteum into the sunburst to the Codman's triangle. That's the progression of the aggressive nature of the disease and what you're looking at. So, and then we come into this matrix of action. So this is something that, especially, if you want to be a rural orthopedic surgeon and you don't obviously have good pathologists in town, you need to kind of formulate a plan that you can't send everyone down to St. Vincent's. So you want to try to dichotomize all of these lesions that you're seeing in front of them to, are they a latent lesion, are they an active lesion, or are they an aggressive lesion? And that's going to determine how quick you're going to act. So something with a narrow margin and no periosteal reaction and no soft tissue mass, like we saw in that very first X-ray I showed, we can start considering, well, this is potentially a latent lesion. And then there's no worrying symptoms, there's no pain. This may have been picked up simply as an incidentaloma on an X-ray. You found this lytic lesion. Well, this is something, if it meets these criteria, you can treat it as latent. And we'll talk about that later. But something, with wide margins or some periosteal reaction, we have to consider that active and start a full workup versus, anything that's aggressive with soft tissue masses, major periosteal reactions, ill-defined. We have to be very aggressive and act very quickly on this. An important thing to think about as well is when you're looking at these X-rays in your rooms, make sure that you have up-to-date. They should be if you're concerned about malignancy, because malignancy can change so quickly. There's certain, a lot of textbooks are saying you should get X-rays that are up-to-date within 10 days, because it may take a couple weeks to get them. So a latent lesion, we talked about with these narrow margins, no periosteal reaction. We can take a wait-and-see approach. So if there's no real concerning features in the history or pain, what you should do is make sure that we always follow these people up. So you should repeat the X-rays in 3 to 6 months and continue to follow them up for a minimum of 2 years to make sure that that lesion isn't growing or changing in any form. And after 2 years, with these latent-looking lesions and there's no progress, then I think a lot of people would say that it's safe to leave them alone, and we can discharge them safely. But if there's any concern at all with the history or any other things, then it's not unreasonable to do some simple bloods, as well as a bone scan if you're worried to look to find any other lesions floating about. Now, active lesions, they always need a full workup, right? And so that would need a full set of bloods. Obviously, your full blood count's going to give you a lot of information. Is there any hemopoietic pancytopenia, things like that, platelet dysfunction? Looking for CRP, ESR, that could be indicative that there can be an osteomyelitis or infection, which is also something that we have to think about. Certainly anyone with an active lesion, we absolutely need to do a bone scan and look for other information. And MRI can be very, very useful at looking at the soft tissue nature and whether there's any further extension in this. And this is an example. These are photos taken out of a JS article in a 46-year-old who had a lesion down here. They didn't look too bad. It seems to have fine margins. And then they went on to find an MRI and showed extensive involvement in the medullary canal, which, as you can see on the plain film X-ray, this patient went on to have a biopsy and was diagnosed with lymphoma. So these are things that you have to be very wary about. And certainly in active lesions, if there's any, the bone scans turn up hot. And now we'll remember all of these orthopedic malignancies should turn up hot. The only thing that we need to be concerned of with a bone scan and be aware of is that multiple myeloma will be cold on a bone scan. So that's the one little key point that you guys have to remember. And we did have a case earlier this year with the cold bone scan, and we had an argument with the hematologist, and we told them it was multiple myeloma. And James was right in the end, and they had to retract their statement that it wasn't. Okay, and then When we look at aggressive lesions, these people need full active workup right away. Obviously, full blood panel. Now, all of these blood tests, they're never going to give us a very clear picture and diagnostic picture. But what we're trying to do is assess the whole health of the patient and see kind of, is there any signs of advanced disease, losing albumin that, it's quite more advanced, and kind of tailor the aggressive nature of ours. If it's an aggressive lesion, all of these patients need X-rays, including chest X-ray, bone scan, and we should CT that specific lesion. We should also start thinking about CTing the chest on an aggressive nature, looking for pulmonary metastases. And certainly, if there's a lesion, now we'll talk a little bit more about metastases in a sec, but once we get to that age where people are, we can't find the primary, or we don't have a diagnosis of where the primary lesion is, a chest abdo-pelvis can be extremely useful in finding where the primary source is. And all of these patients with an aggressive lesion do need to have some form of biopsy. Now, biopsy is quite interesting because we need to make sure that obviously we have a diagnosis before we go on to treatment and finding a treatment plan. Now, there's been a lot of stories about biopsies being done poorly and spreading of the disease, or not getting enough tissue, or the other concern is if we don't have a very narrow idea of what the possibility of the tumor could be, that makes it more difficult for the pathologist, especially inexperienced pathologists, to come up with a definitive diagnosis. So that's why we need to go through this whole workup process to try to narrow down what our differential diagnosis of that specific lesion is. Now, I think, and certainly in Victoria, we all know that St. Vincent's in Victoria is the Musculoskeletal Tumor Centre. Now, the benefit of them is they have the combination of experienced tumor surgeons who will be able to do biopsies, radiologists, who can do fine needle biopsies and things like that. They do them on a regular basis, as well as the pathologists are very, very familiar with musculoskeletal tumors. So your diagnosis is going to be a lot easier, and the damage to patient is going to be a lot less. We need to make sure that we mark out the tract of where we go in for a biopsy, because if it's confirmed diagnosis of cancer, we have to make sure that there's an excision of the biopsy tract. And again, when you're going through surgeons who are familiar, or the surgeon who's going to resect the tumor should know where the tract is. And if they do the procedure, then everything fits a lot together. So biopsy is very, very important, and we have to be very careful when we're biopsying, and we're not going to be the ones who are going to do the definitive surgery, because there is that possibility of seeding tumor cells into that local area and causing harm to the patient through this process. So obviously that all those experience of surgeons, radiologists, pathologists is very, very important for coming up with a definitive diagnosis and making sure we don't harm the patient anymore. Then we need to consider the margin of excision when we do go through. So this is a picture taken out of Miller's. So there's 4 different margins we have when we're resecting tumors. Obviously, an intercessional margin is when we go through the tumor, so that's trying to curette or debulk the tumor as much as possible if there's some concern that taking out all of the tumor may do further harm. This is obviously something that's going to be more common in, say, neurosurgery, where you're trying to leave as many brain cells as you can. They talk about the reactive zone of the inflammatory or reactive tissue around the tumor that isn't actually tumor cell itself. So a marginal margin will be outside of the tumor itself but go through that reactive zone. Now the recurrence rates of intercessional resections are very, very high, some up to 100% recurrence. You have to be aware of that. So a marginal margin may be appropriate for a tumor that is reacting already to chemotherapy or adjuvant therapies preoperatively to reduce it. And if that works well, a marginal margin may be beneficial, may have a good chance of reducing your rates of recurrence. Now, a wide margin, obviously, we're going to come well outside the reactive zone, trying to reduce the risk of recurrence. And then the next step would be a radical, when you take the entire compartment or the entire leg. That's something that the neurosurgeons do have over us, is they never do radical resections of the brain and have their patients continue something that they could say, well, you guys can take a whole leg off and the patient will still have a reasonable life. And then, so once we've gone through, so we've done the workup, we've had the X-rays, we've gone through, and we've done the margin or the biopsy and the resection. Then we have to stage the disease, and this is the most commonly used, the American Joint Cancer Classification System for primary bone tumors. And its stages 1 to 4, so we're common with these. And it looks at the grade of the tumor on histology, the depth and size of the tumor, whether there's any regional nodes or metastases. So important things to note: if you have any metastases, whether that's to a lymph node or to a distant site, then that is by definition a grade 4 tumor. The G1, G2, G3, and G4 looks at how well differentiated the tumor cells are on biopsy. So the more differentiated the cells are, the lower the grade. So when all the tumor cells on biopsy are completely undifferentiated, that would be a grade 4 tumor. Looking at the tumor size of 8 centimeters seems to be the size, or whether it's penetrating outside the cavity of that of where it's found. So if it's penetrating outside the bone, then that would be considered a T2 in regional nodes. So 1 is obviously the lower grades. 2 is higher grade differentiation, grades 3, grades 4, and then A and B is differentiated by the size of the tumor. And then grade 3, whenever there's any skip lesions where the tumor has penetrated outside of the bone, then that's considered a grade 3. And then this was poorly defined for a long period of time. And then, like I said, grade 4 shows any metastases, whether the lymph nodes are further down the train. So now we'll go and talk about the patients over 40 years old, which is certainly the patients that we see more commonly in this hospital. And we have to remember the 5 Bs, this is how I've remembered it, that go to bone, the common tumors that go to bone. And that's breast, bronchus, thyroid, kidney, and prostate. Now, some other people think that good things come in pairs. So obviously you have 2 breasts, 2 lungs, 2 lobes to your thyroid. You've got 2 kidneys, you've got 2 lobes to your prostate. So these are the most common lesions. So when you have the older patients, the most common source of a lytic lesion or some kind of tumor in the bone is going to be a metastasis. That's the most common thing. So we've got to rule these things out and go looking for these things. So we also have to think about myeloma and lymphoma are also certainly, myeloma is a disease in people of their 50s, 60s, and 70s. And lymphoma tends to happen in people 30, 40 years of age or older. Primary bone tumors are much less common in people over the age of 40. So when we do have that lesion, we find it, so there's a few things we have to do. One is we first have to work out, do we have to do anything about it immediately? And do we need to fix or prophylactically nail these papers? So we've all heard of Murals Score and Murals paper, which was published out of South Africa in Clinical Orthopedics and Related Research in 1989. Interestingly, it was received by the journal in 1985 in December, and took 4 years to publish. It wasn't published until 1989. Which is interesting because this is a landmark paper that we're still talking about, 20 years later, and it dictates what we do. And what they did is they took 78 lesions in long bones of people. It was a retrospective study going back through the years. And people who are about to start radiotherapy for bony lesions, metastatic lesions, and trying to find out some score based on all the different papers published in the 60s, 70s, and 80s about how do we determine whether we need to fix it. And the Murals Score is out of 12, and you get 1, 2, or 3 points depending on 4 things. So the site, whether there's pain, whether the type of lesion, and the size of the lesion. Now, so upper limb is 1, lower limb is 2, and peritrochanteric is considered a 3, so higher risk of fracture. Now, pain is mild, moderate, and functional. And it's not very well defined, but in the paper itself, but functional seems to imply pain on weight bearing or any form of activity. It's considered that there's stresses and the bone itself, periosteal, is being stretched and the trabecula are about to fail. Now, the type of lesion, whether it's a blastic lesion versus a lytic lesion, is 1 versus 3, and if it's in the middle, obviously it's 2. And then certainly the size of the lesion, if it was under 1/3 of the size of the cortex at that area, it was much less likely to fracture compared to these lesions which were greater than 2/3. So you can see you ought to, the lowest score you can get is 4. So if you have 3, you're already at 6. So if you have any other kind of mixed pictures. So all these ones are high predictors of fracture, these ones on the end. But what he's done is it became very clear that if you had a score of 7 or under, then you can be treating that as a non-impending fracture. Or if you had a score of 8 or more, there's a very, very high risk of fracture. And that went from, if you had a score of 8, you had about a 30% chance of fracture. And that went up to 50%, almost 90% if you had 10 or above. So it's important to know, certainly for all the orthopedic registrars. And they also found that lung cancer was associated with very, very high rates of, periprosthetic fracture is wrong, but pathological fracture, very, very high rated. Now, interestingly, in all the different papers I was reading, there was one JS article that was suggesting if you had a single lesion, even though that they were age 40 and above, and even if you had a known primary, you should still consider doing a biopsy on that lesion prior to nailing any of these fractures, which I haven't seen done in my own practice. And this was something that I think would be interesting to talk about, is if you have that single lesion somewhere, whether it's the femoral neck or the humerus, we have a known diagnosis of cancer, but are we going to put all our faith that that is definitely the cancer? Because certainly there's cases. There was, one case they presented of a pathological fracture of femoral neck that was treated with a DHS, and the patient actually had a primary osteosarcoma. And reaming or nailing an osteosarcoma is a very, very bad thing. Now, if there's widespread disease, bone scan picks up widespread disease, and we've got a known primary, then we can probably safely go on and treat the fracture. But if these single lesions, I wouldn't mind discussing that after the talk is finished. So workup for any of these metastatic lesions, we talked about obviously plain film X-rays. We could get a Murals Score with the history. You can talk about whether you want to treat it. Then you have to work them up further. Bone scan to look for skip lesions, any other places. It's really important that we X-ray the whole bone that we're going to fix. Certainly there are cases of femoral neck lesions that are treated with hemiarthroplasties. The lesion below, the stem or where we put the cement mantle is not picked up, and then you can have a further fracture and you've given them the wrong treatment. Skeletal survey is useful in myeloma. Obviously the bone scan is going to be negative. So skeletal survey of X-raying all the long bones in the skull to try to pick up any other lesions. Now CT, depending on the paper you read, there was reports of 25 to up to 89% of cases where there was no known primary and there was a bone lesion if you did a CT chest abdo-pelvis. So up to 90% of cases when you don't know the primary, CT is scanogram, like you're in the Alfred emergency after a trauma, you're going to pick up where that primary lesion is. So that's something to think about too if you don't have a hard diagnosis before their operation. And then So I think we've talked about whether we should biopsy these lesions, and hopefully some people have some interesting comments afterwards. And then never ever forget infection. All right, so we always get fixed on tumor. There's a lesion in the bone. There's no particular symptoms of infection, but always be aware of that. That's something that's important. So when you're sending off these histology results, especially from metastases and things in the older population that we see much more regularly, make sure you send some off for culture as well to see if there's some kind of infection as well, because they can certainly behave like a tumor. Or if you think that something's infected, never ever forget about a tumor. So in summary, people under 40, if there's metastatic lesions, certainly in the younger categories, below 30, you have to be very concerned about the pain of lytic lesions on X-rays of metastatic disease, and we have to work them up very carefully. Over 40, much more common is to have a metastasis, but you just have to be careful that you don't get caught out and miss a primary bone tumor. Plain film radiographs, good quality plain film radiographs are very, very important, and you can get a lot of information out of those and kind of dictate how quickly you're going to progress through your other investigations. And you need to make sure that they're tailored to the story and what you know of those kind of tumors or what it may or may not be. Biopsies need to be carried out with very, very great care, and we should probably at least discuss this with a primary oncology, orthopedic oncology unit prior to venturing off to doing biopsies on our own will. And for metastatic lesions, we've got a very good scoring system about whether we should prophylactically fix them or not. So make sure you're aware of that. So thank you very much for having me.